coming from long-term care and hospice, we thought of everything in per patient day. So everything was a factor of the actual number of patients, which is not the way to look at palliative, in my opinion. You don't look at palliative that way because the frequency of visits are not consistent. You have to change your production measure to measure the visits. So when you're driving your staffing model, it's based on the production, not the actual number of patients, because I could have 100 patient census and on one end, I'm only seeing them once every 45 days, or I may have 3 times a month or 4 times a month. And what we found through analyzing it, if you had to put it to a patient census, is on palliative, you'll see them real heavy in the front, you'll trough out, and then as they get closer to more critical, then you'll have an uptick. And you've got to look for that proper hospice referral at that time. But it averages out over time to approximately about 1.5 times a month visit if you had to do on census, but you've got to measure production, because if you staff and don't measure production, you're going to go way over on your spend, on your labor. You have to know. And then the other thing that we did, which was in error, is we started off coding so poorly that our average return on a bill was grossed down to about $40, where it should be about $108, $110 per billing. If you're actually doing the work and taking credit for the work and appropriately documenting. And so what I have found, the way we do it, you've got Crossroads as an umbrella that happens to have 2 different services depending on what the patient needs. It's all about what the patient needs and what they qualify for at the time. So you happen to have hospice, you happen to have palliative, but by growing the palliative, we had to increase the number of nurse practitioners we were hiring. We didn't know how to train, monitor, or evaluate or assess nurse practitioners very well. And so we get all these nurse practitioners that come in because they've got palliative experience, and now they're also the ones doing face-to-face, but they don't know anything about hospice. And so what the biggest hurdle that we had to overcome starting palliative was the cannibalization unintentionally of our hospice census, because all of a sudden everyone was palliative. It was easier. It was an easier conversation. I didn't have to break the news to the family. And then once we got them on palliative, then palliative wanted to keep them. So they didn't recognize themselves as under one umbrella. The biggest mistake we made is our palliative services considered themselves separate than hospice as opposed to under one. And that's the massive retraining and retooling that we're doing. The way I've got it structured, we are a nurse practitioner driven business because the gatekeeper between the two is the nurse practitioner. Because if I admit someone on palliative and they do qualify for hospice and should have hospice, I don't want to make that mistake on the front end, but if I do make that mistake, I should be able to correct it by the first IDG. Same way with hospice. Should I admit someone on hospice? Let's talk about decline for a second. Has Perry talked to y'all about decline ever? Because I don't want to. Okay. So what we did when we started palliative and to decrease our length of stay is we took with the 11 sites, so we had a really good sampling. And we took patients that had been on service, we went back and looked at patients that had been on service for almost a year. And then we reverse engineered from the time that they died, we opened up so many charts per site, I think 20 charts per site, and took those patients and went backwards, and we gave them 22 different measures of decline. So medication changes, weight loss, all the infections. Any one of those instances is or could be decline. And what we found was in the last, I think it was 60 days, on average, our patients that actually trended and passed would have an episode of decline at least once per IDG, at least once per 2 weeks. So what we did was we started by self-imposing in our assessment decline as a factor, even though the LCDs don't count it because the fiscal intermediaries do. So we started, that was kind of so when you go see a patient, so you got hospice and you got palliative and you go assess a patient for admission. or you're looking at a patient long-term, whether they're on hospice or palliative, when you can track that decline that is consistent with your own records of when patients are passing away and what Medicare, or not Medicare, but what the fiscal intermediaries want them to pass away at 60 days, then you can work backwards. You get that decline, and if you don't see a decline in a hospice patient, you very well may have a circumstance where they're normalizing, and having palliative gives me a way to move those back and forth. I can take care of a patient and still maintain the contact with moving them to a palliative service because they seem to have stabilized, or if they're on palliative and they make a decline, then I know that it's time to start working towards a transition towards hospice. Yes?
What criteria are you establishing to actually admit into a palliative program?
I'll skip ahead and get to that right now. Actually, he's got a question that I think more appropriately does that. Make sure I answer it, and if I don't, please say you still didn't answer it. Okay? Thank you. Go ahead. So,
at what point, when you started, you said
right.
that
I'm not even paying attention.
you started. Yeah, I thought we could throw those away. At some point, you said that
far off track.
you had separate, really you had separate different teams. You had the palliative team and you had the hospice team. They weren't really working together. What were the early indications that you might share with people to look out for that says, okay, we're really not integrated. We're going down the wrong path. If you were to look back at it again, like you did on assessment,
Yeah.
how would you have looked back and said, aha, there's a problem?
Your hospice census craters. Because all your referrals, however anyone handles your referrals when they come in, I would urge you not to, and take every step you can to avoid prejudging either way what a patient is before you actually go see them. Huge problem that we had, because now all these referral sources where I'm wanting to expand, I didn't expand my footprint. All I did was I quit marketing the hard hospice and started marketing the easy palliative to the same people. So that's what cannibalized my census. So now I've got my marketers and my nurses and people going out and talking to people, because palliatives, we've got palliative, and that's sexy and everyone likes that. And the doctors get to keep billing, and we don't have to tell the patient the bad news or the truth.
Right.
And so now there's the easy buttons in your hospice census. What's happening? Why did it take me 20 years to grow my hospice census and I tripled my palliative in 6 months? So growing too fast is a clear indication you're doing it wrong. Plain and simple.
When we first started dialoguing, you and I and Perry and some other people 4 or 5 years ago, or 4 years ago, about palliative care, we truly believed that there would be people that would be motivated to pay for palliative care. That was a fallacy.
Yes.
It's
a little early.
Thank you. Where does the funding come from to sustain a palliative care program
Right now,
in today's world?
Right now, we just bill the visits, and we've got a sustainable model just billing the typical Medicare allowable visits. Now, the other yes.
Real quick, so what's your staffing model look like? Do you have social workers? Do you have RNs as part of that program, just so we can kind of base?
I've got nurse practitioners. We started off with everything.
Yeah.
And it's basically because of, Mark always asks about the standalone model, whereas mine is a combined model. It would work standalone numerically, but it's a little trickier. But I have peeled back to just nurse practitioners, because the social work needs I can handle. I've got the bandwidth because of my social work staffing model within my hospice. I've got the bandwidth. I may add one. I may just do a +1 on my budget staffing and just let that handle it. But that way they can handle it because they're already regionally located by virtue of my hospice census. So they just kind of take care of it there. The other thing we do, because we've got so much from the billing in and the visit scheduling and stuff like that, the other additional FTE is we run, so the nurse practitioner runs at the number is 1 per 125, and again, I know I just used a ratio I told you not to use, but that's with the visits built into the 125, because I'm assuming 6 visits per day. Okay? The 6 visits a day.
Or are they contacts, or
The-
are they true visits?
True
or
visits,
patient
true
contacts?
visits,
True visits.
okay? And the reason it's not 8 is because of, I do have some drive time considerations. I do have face-to-faces that they have to meet sometimes. So I personally like to staff any employee at approximately about 80% of what I think their max load is, because we all know we have periods of time where it's 110%, and I can't ask someone to give me 110% every day of the week. I'm not gonna keep them. And so the 6 visits a day is kind of an 80% number to me, because I know they can go up. The other thing that really helps with a palliative program from a monetary standpoint, and we have successfully done this really well in Kansas City, and we're doing it now in other cities, is a lot of these hospitals don't really have good palliative programs, and they don't want to staff them. And so we have successfully become their palliative partner, and so we've got nurse practitioners just embedded, and they're doing, so now they're cranking out 9 or 10 or 12 palliative consults because there's no drive time.
Is that all inpatient, or are they in clinics as well?
They're all inpatient.
All in.
Yeah, and then of course we're for their, when they go out, then we take them as an outpatient outside. Yeah. What were we talking about before that?
Do you have a contract with the hospital that then they use?
You don't have to.
Do you just charge them for the?
You know, it started off, it's gone multiple ways. And it always falls back, every situation I've had, which doesn't mean it's right or wrong or it's gonna be the way it's always is. Everyone starts at hey, we'll pay you $2,000 a month to be our palliative program. You know, you do the visit, you submit it. It always falls back to, because as soon as the CEO sees the first year, they're going, why aren't we paying you anything? The best way to do it is just go in and say, we're not exclusive. I'll get all your business because I'm going to do the best job, and just eat what you kill. That's the sustainable model. Everything else gets modified and changed along the way. But that inpatient services can make or break the monetary, the financial viability of it, because on the 6 visits a day with the average billing, you're kind of about breaking even on your palliative program. But the inpatient is a lot of because the volume, the production is 50% more than the outpatient. So you have that opportunity to pad your deal. When you think about the monetary value of palliative, in my world or in my mind, I can't separate. It has multiple values. Can it pay for itself? One, yes, it can. But you have to staff it right, and you have to have the production. You can't have nurse. Are there any nurse practitioners in the room? Okay, I apologize, everyone except for you. You can't live in a world where they're so busy they only make 2 visits a day. You just can't do it. It's like having an admit nurse that can do one admit a day. Well, okay, it numerically doesn't work. So, what was I saying? See, that's why I had the notes.
I mean, but you're talking about the financial model. And
So how on earth, the palliative standing alone, yes, but what value do you put on it for your hospice? You know, has anyone had a Z-pick with an extrapolation? How much fun is that? No? Are you serious? No one? Okay, for those of you that haven't raised your hand, good luck, because it's coming.
Should you bill under 2 separate tax IDs?
No.
Okay, so
It's all under one company. I think. I've got no problem saying I don't have a clue. Okay, but I
Just one's
think,
going to A, Part A, and
Yeah.
one's going to Medicare
Yeah.
B.
Yeah.
but you know, so where do you put the value on your hospice? You know, I'm always right. You know, right program, right time. Right program, right time. You know, so whatever that, I've got 2 services. So what the patient needs is what I ought to be giving them. And I shouldn't be letting the patient or the family, without making every effort I can, not choose the right program. And so if you can protect your hospice census, if you can build your bench with palliative, all those palliative patients are going to be hospice at some time. So they have a value to your hospice unless your palliative's hanging on to them and they give them to you the day before they die because they're not recognized. So let's talk about decline again. When we implemented the decline, you have to put that parameter on your entire population. You cannot be discriminatory and admit everyone to hospice, and then once they hit a long length of stay, start implementing. I feel personally, from a regulatory, just to be safe, I don't look good in orange. So that criteria is at the point of admission, and every single time we evaluate at every IDG, it's IDT now, showing my age. But that criteria is applied across all patients at every point, whether it's the first day or the 100th day or the, God forbid, the 1000th day. It's the same criteria. That way you are not discriminatory. You apply it to every single patient going in. So I caution you to make sure you set it up that way and that your staff understands that.
Early discussion of palliative care where there was a perceived significant difference in the care model, the care plan from a hospice patient to a palliative care. Dr. Tim discussed with you and I one time in Kansas City a great detail about how much more difficult it was to put together a palliative care plan by diagnosis. How difficult is that as a challenge for putting together the model in which you're going to care for these patients?
Well, I disagree with Dr. Tim.
Fine. Can you defend that?
Well, I don't think, first of all, that wasn't a question you gave me.
Nobody just don't tell Arvin this because he's going to go, I'm leaving.
Yeah, I mean, I really don't. I don't get, and maybe it's my lack of clinical knowledge other than what I dream in my head of imagining that I have that. I don't see what the difference is. You know, you could care plan. I could care plan my knee. It's just a short-term care plan. I mean, you can care plan a palliative patient. What's the difference? The difference is what you're care planning. You should still be able to build the same care plan. You should be capturing, because we are one agency with two programs, I want to treat my palliative patients from a care plan or a documentation. I want to treat it all the same because I want all of the KPIs on those palliative patients on my transition, because now as the software matures and you get into as the business matures, now you can get into the analytics. Now I'm not just dependent on my clinicians to help me point. Now I've got analytics that show that this patient should go over at this time. Or more importantly, if I start with the palliative patient, and let's say I start with the palliative patient, I move them over to hospice at the right time, and then I get an audit and that patient's still on and I get a denial, I want to see that the decline or the KPIs started off here, and you can graphically see as they started to go off, this was the point we did the hospice admission. Or conversely, here's my hospice patient that was going down, and then graphically be able to show that they have stabilized, so therefore we successfully, we made the right. If you have a palliative patient that's been on your service for a year, you made the right call. If you have one that's been on there 14 days and passes, you failed to have the right conversation. Period.
Okay, so speaking of conversations, I want to go back to the point at which you're
Are we going to get back on our points now?
Hopefully.
Okay.
We're going to go back to the point at which you're having an early discussion with the patient and the family. What's the key to having a team successfully trained to making the right call at the right time?
You stated it. It's all about training the team. We have run up against matter of fact, we've run up against so hard, we're starting back at square one. We are having a tremendous, because of the palliative and everyone falling in love with that, and it's so easy, and I get, when I'm an assessment nurse and I go out, my admission takes me 15 minutes or 30 minutes instead of 2 hours. Well, I'm changing that. I'm trying to break behaviors however I can with the initial assessment and going back to your care plan. I don't care if you think the patient's palliative. You're going to collect it's going to take you just as long. I'm taking away the easy button. I want every piece of data you would put on a hospice patient on that palliative patient. I want a care plan. I want all their meds. I want everything, because eventually when you get to that payment source you're talking about, you're going to have documented patient outcomes. So you're going to have to know where you're starting, or you won't be able to document the outcomes and prove them.
Are you able to document this kind of data that you're talking about inside the EMR that you're using?
Yeah.
Or do you have to use it as a standalone separate because the EMR doesn't
No,
participate in palliative data?
I'm going to do it with my own EMR. I want the same EMR both so I can share the data. And so I can pull. So, huh?
What EMR are you using?
Which EMR are you using?
The Carrefour, because of it's built around a care plan, not the ability to bill.
Okay, it says for both palliative and the
Yes.
hospice.
Yeah. Yes.
First of all, I agree with you about care planning. It's intrinsic to all healthcare. Palliative care would be no exception, right? It's the roadmap.
How do I know what's driving my next visit if I don't have a care plan?
Right, it's the roadmap to care, right? But my question was, when you talk about decline, since you know there are like 22 factors you're screening, and so did you create a screening tool that cues your palliative care team that, hey, you have this many decline ticks off, you need to refer to hospice?
Okay, well, yes, but what I'm trying to do is, again, when we talk about decline, I am doing my best to create an environment to train everyone on both programs. You're not one or the other, but my key, to your point, I'm a nurse practitioner. I've unintentionally created myself a nurse practitioner driven business. So that's my key. So what I did was, and I hope I made the right decision, I really think I did, but with my team that goes out and helps manage, you've met a bunch of them. I've actually hired a nurse practitioner from Australia. And the reason I hired one from Australia is because I like her accent. But I got an opportunity to work with her a year ago, and because of the world she lives in, where the decision on the level of care is not financially motivated, the actual conversation is very easy for her. And so I want that to and she's a go-getter. You could use multiple terms for that, but she's aggressive as far as, she is to the point and does her job very well. And so I want someone, I'm kind of going back to square one, recognizing that I have got a deficit in my nurse practitioner level, and I lost it when I went from being hospice and having these face-to-faces having to be done, and the value of that documentation on that face-to-face, when I started growing my palliative program so quickly. And when I say I or my, I really mean we. It's just a habit. I don't mean it because we did it as a group. But when I started hiring nurse practitioners, I just did it again. When I started hiring nurse practitioners for palliative, I turn around and wake up and they don't have any hospice. They don't even know what hospice is. And now look at the value of my face-to-faces. It's just, so I'm literally going back to square one and starting with, great, you're a palliative nurse practitioner, love it, you're smart as can be. Let me teach you what hospice is and what it means, with the decline being a large piece. That's our gauge, is the decline.
We talk about unintended consequences of good decisions all the time. So just recap, what are some of the financial unintended consequences of having a program in which you have it clearly defined? Thank you.
Finally, you asked a question that we prepared for. Now I've got to find it. Okay, unintended consequences. Yeah, you're on number 6. Okay. So we've talked, to recap what the unintended consequences were. The number one was unintentionally cannibalizing my hospice census, because everyone fell in love with palliative because it was easy and we didn't have to do as many after. That was the number one hurdle that we had to overcome. When we started, now see, I'm blaming it, now it's we, not I. When we started it, not having the production measures, so we weren't measuring it appropriately, so it's like a snowball effect. We started off with the wrong idea or the wrong tool, and it just keeps getting worse and worse and worse. And nurse practitioners are paid every dime that they're worth, but they're not cheap. And so that is that is a very expensive FTE to miscalculate how many you need and what work you should be getting out of them. And then basically not knowing what we didn't know. You know, starting off, you know, on the Nike version, just do it and say, well, hell, I got this. I'm gonna hire a nurse practitioner for every 50 patients because that's what I do in hospital, you know, or whatever that deal is. And you end up grossly overstaffed. And again, all of a sudden, one visit is a full day's work for a whole group of people. And so I've got to retrain those habits, which is easier just to fire them all and start over. Perry has never fired an employee in the 22 years. Guess who always gets that job? Always, yes.
Real quick, when you were talking about the insurance piece of it and having data to take to the industry, whether it be the MCO or...
Now we do bill insurance.
Yeah,
Okay,
yeah.
and we get the visit. I'm talking about that next, the one everyone talks
Like
about,
capitated,
where you get these
model.
shared savings models and stuff like that. I'm saying there's a lot of talk about it, and someone in this room may be doing it. Either we're not smart enough, or everyone's keeping it hidden from us.
Well, that was
It's gonna happen.
My question was where you were kind of deriving your data, because a lot of that comes down to 30-day hospital readmissions and the value proposition to the healthcare system. And
That's question number 9.
I will defer to question number 9.
But no,
So I wasn't sure if you just had a mechanism, like, we try to work with our health system to match up patients on our palliative care service, the hospital readmission rates, and kind of do that in their board on quality
Right.
report outs from the health system side. I wasn't sure if you had a good data set.
So I don't know if it fully answers your question, but I mean, I could literally go the entire hour just on data points to measure that I think are important, whether they are or not. It's up for you to decide. But on the analytics, the number one is the patient outcomes. You know, the hospitalizations, the frequency of, you know, how often were they hospitalized? How does that compare to another sample size? You know, cat behind you. You got all kinds of, you know, everything we were talking about last night, you know, all this analytic data that you're measuring these KPIs. But the other KPIs, so that's the information where I, earlier when I started, was talking about, you know, we need to, as a group, do the service, do it right, gather the outcomes, and be able to go to providers or payors and have the data to prove what we do. Not just say what we knew, not just theory, but here, I've got here's a year history. You want to talk about this one diagnosis? Look at this. Let's compare my outcomes to yours. You know, people without our service, how frequently are their readmission rates versus mine? But then you get to the other analytics. I think these are key for you running the system, as we've talked about, the production per FTE, because if you're not measuring it, it will bite you. The length of stay on palliative. The length of stay when you transition from palliative to hospice. 2 days is not good enough. We spoke to a young lady, and it broke my heart. We were in the hot tub yesterday, and a young lady was not real happy with hospice. She had hospice for her father, and it was during the holiday, and he was on service for about 2 days. And because it was a holiday, she didn't get anyone to even answer the phone and come see him for the winter. So it's like, you know, how much do you apologize to that woman for the experience she had? But I don't care if you answer the phone. You can't do, now you can control the pain, and you can have, you know, 2 days, you can more than likely clinically, but for what we do, you're missing out on so much of what all the benefit we could offer to the patient, and more importantly, the family and the caregivers. So me having a 2-day length of stay transitioning from palliative to hospice is not acceptable. And I'm doing it to myself. So that I've got to learn to control that. And by having the metrics is the way we do that.
So if you have somebody go out, you get a referral from a physician, you don't want to say no, but you get the referral and they're not eligible for hospice. What is your process? Do you have a hardwired process for then transitioning them to a palliative care referral? And which team does that fall on?
Okay, did the physician make a hospice referral or just a referral? A hospice referral, then it would be, in my organization, they're going to get looked at by one of two people, ideally. They're going to be looked at, I changed my terminology from admission nurses to assessment nurses, for the sole purpose of making it very clear to them that they're going to do the same assessment on all patients and then decide what program they come to. So it's going to be them or nurse practitioner. Why would a nurse practitioner do the initial assessment? Under your circumstance, it's almost 99% of the time going to be an assessment nurse because we think it's a hospice admission. They just didn't. So we're going to call the physician and say, look, here's where they are. They don't meet criteria. Well, what do you mean? They don't meet our criteria, and here's why, and here's what we're going to do. And it's having that conversation with the physician. Let's flip it. When would the nurse practitioner be the one doing the initial assessment and doing the same paperwork? Well, I have a physician who is almost exclusively, I mean, they don't call in a referral, they call in a palliative referral. And we've already been round and round with this physician or this clinic. And they're like going, damn it, that's the first curse word I've said.
That was really well done.
Very peachy.
And so we've already worked with them, and they're like, and this actually happened in Memphis. We have already spoken to the patient's family, and we're actually making families mad because they are having the conversation again. We promise you these are palliative. So my nurse practitioner goes out to do they're not going to do an admission, they're going to do the same assessment to get the very first care plan started, gather the meds, so I've got my key data points on the front end. They're going to do the exact same assessment, and then most likely admit to palliative because that's probably where the patient belongs. However, if they meet my criteria and decline, you pick up the phone and you call the doctor and you get the right program for the right time on that patient.
Thank you.
You're welcome. Easier said than done, by the way.
Yeah.
It's in my chair, it is clean. It's so easy. Getting it done out there, absolutely. Yes, sir.
Oh, do you have a rule of thumb as far as, obviously you want to get them 18 months out, I mean, kind of an optimal model, not.
And that's a guess, yeah.
Okay, do you have any kind of rule of thumb about how many visits you'll have on a monthly basis or, for each patient?
If I can kid in that 18 months, that's where my rule of thumb is hitting at that 1.5 per month on average, with the front end and the back end being a lot heavier. So you get that trough of visits. Should we end up with let's talk about visits with unfundeds. Because a lot of these unfundeds, they may be funded through Medicaid or something on hospice, but they're just unfunded on palliative, or just with unfundeds, because again, I don't want to piss off my referral sources. So what we're trying to do right now on unfundeds is, if you're unfunded going in, and we know it, we may be in the process of getting a contract with your agency, whatever it is. So even if you're unfunded, we'll do the first 2 to 3 months. We're going to do that. We just can't have, because they ultimately end up staffing, visit assumptions is relative to census. And so you don't want to end up with 9 nurse practitioners when you only need 4, because 300 of your census you never visit. You've got them stabilized, they've been on for 3 years. You've got to quit counting those people, because you'll end up inadvertently staffing for it. So you're staffing for non-production.
Yeah, you really have to just staff for visits.
Yeah,
I mean,
and we learned that the hard way. And when I say hard, I mean expensive. Yes, ma'am.
What education tools are you using for?
I can't hear you.
What education tools?
Oh, Dr. Tim, that's my answer for that. Dr. Tim is my education tool. I mean, we've got a really well done, in my opinion, the SOPs that we have from the LCDs to decline and the activity. We've got it really well documented that the nurse practitioner, for example, that is just knee deep in getting this started and going out. And my whole deal is I love education like this in a classroom setting, but I argue 9 ways to Sunday, until you get off your butt and go spend a day with him, you're never going to teach him how to do it right. You can sit here and talk theory all day long, go show him how to do it. And so that my education is more how to practice it, not what tools you're using.
Clayton, thank you very much.
Are you cutting me off?
Yep, sure am.